who is also a consultant pediatrician with an interest once again in pediatric neurology. And I'm very excited to see so many people interested in pediatric neurology, because that's an area that we do need more consultants. So over to you, Dr. Amolo. You can please begin sharing your slides.
Thank you.
Welcome.
I hope you can all see my slides.
Yes, we can.
All right, good afternoon, everyone. As I've been introduced, my name is Dr. Lucia Amolo, and today I will be discussing management of childhood arterial ischemic strokes at the Kenyatta National Hospital. So we'll start with this case. So you're working in the pediatric outpatient. A 5-year-old boy with sickle cell disease is brought to the emergency department by his father. The father states that 1 hour prior to arrival, the boy started stumbling while walking. The father says he didn't think much of it until he noticed the child's speech was a bit slurred. He also says that he thinks that his son's face looks a little bit odd, different on one side, although you cannot appreciate the facial asymmetry when you examine. The boy has 3 out of 5 strength of the left arm and the left leg, as well as dysarthria, which is abnormal speech. He's alert and he denies any headache or visual changes. The rest of the neurological examination seems to be normal. The boy's vital signs are unremarkable, except for a mild elevation in blood pressure. So you, as the medical officer, are concerned about possible stroke and begin to think about what tests you should order before you call the consultant, as well as which specialist you should consult before initiating treatment. So just as you're thinking about this case, you walk into the other room and you then see a 2-year-old girl who was brought to the emergency department by her parents after she fell forward with a toothbrush in her mouth, which commonly happens in our pediatric patients. The mother removed the toothbrush from the unconscious child's mouth and noted that there was a bit of blood on the toothbrush as well as in the child's mouth. Although the child was unresponsive about 30 seconds after the event, the mother reported that she didn't really notice any seizure-like activity in her child. So on presentation, the child is alert with a normal mental status examination and the normal vital signs. She has no obvious intraoral trauma when you examine orally, no abnormal voice, no stridor, and she has a normal neurological examination for her age. So given the loss of consciousness and the report of blood on the toothbrush, despite no oral laceration seen, you decide to obtain a CT angiogram of the neck. You do a CT angiogram of the neck and it shows a dissection of the left internal carotid artery with subcutaneous air in the area. You consider what treatment to initiate, which specialist to consult, and whether further imaging is needed, and what should be done, what should be the disposition of this child. So these cases are very different presentations of childhood pediatric stroke, and this will be the basis of our discussion today. So this is our outline. I'll define and classify strokes. We'll go over the blood supply of the brain. I know sometimes neuroanatomy can be quite difficult. Once we understand the blood supply of the brain, we'll be able to explain a lot of the clinical presentation. We'll also discuss the functional areas of the brain. We'll discuss the etiology and risk factors for arterial ischemic strokes, as well as management of arterial ischemic strokes and what we can KNH. So let's begin by defining strokes. So the World Health Organization defines a stroke as a rapidly developing clinical sign of focal or global disturbance of cerebral function, with the symptoms lasting for 24 hours or longer, or leading to death, with no apparent cause other than vascular origin. So I want you to look at the highlighted sections. It's rapidly developing. It's focal usually, but it can be global, and it's a disturbance of the cerebral function. It lasts 24 hours or more, and no other cause except vascular origin is determined. So how do we classify childhood strokes? So pediatric strokes can be classified as hemorrhagic or ischemic. My focus today will be on ischemic strokes. So for the ischemic stroke, we can classify a perinatal or childhood stroke. A perinatal stroke is a stroke that occurs either intrapartum, during delivery, or within the first 28 days of life. Any other stroke occurring from 28 days of life to 18 years is considered a childhood stroke. So the ischemic stroke for childhood can be either arterial or venous. So for the venous, we have the cerebral synovenous thrombosis, and for the arterial, we have the arterial ischemic strokes. So for the perinatal period, again, the stroke can occur before birth, as I mentioned, that is the fetal period. Again, can be arterial or venous. The neonatal period, that is at birth or within the first 28 days, again, arterial or venous. And we have this classification that's called presumed perinatal ischemic stroke. Why do we have this classification? It is because sometimes neonates have very subtle and small changes when they have a stroke, and it may not be detected until later on in life, even 6 months or 1 year. So when you determine a child, for example, is coming with a preference to use the left side of the body, this child is 6 months, you do imaging, and it's suggestive of a chronic infarct, then you suspect that this child probably had a presumed perinatal ischemic stroke. So let's go over the blood supply to the brain. I hope I've tried to simplify this diagram just to make it easier for us to understand. So this is the brain is a part of the central nervous system. So we usually have the cerebrum and the cerebellum. Then we have our midbrain and our brainstem. So we have our midbrain, our pons, and our medulla, which make up the brainstem. So the arterial blood supply is divided into an anterior and a posterior circulation. So the posterior circulation, will begin with that, is usually originating. So all the anterior and posterior circulation usually originate from the aorta. So the aorta, we know, has 3 branches: the brachiocephalic, the common carotid, and the subclavian artery. So if we follow the brachiocephalic artery, we see that it gives off the subclavian in the right, and it comes directly from the aorta in the left. So we see the subclavian artery giving off this vertebral artery. So the vertebral artery runs through the vertebra, specifically the foramina transversa, and it emerges in the brain. When it emerges in the brain, it emerges from the caudal or lower aspect of the brain, and that will be at our medulla. So we can see our right and left branch of our vertebral artery. It runs up and forms the basilar artery. So this basilar artery are what supply the posterior aspect of the brain. So we can see there are branches that run to the cerebellum. We have what we call the posterior inferior cerebellar artery. We have the anterior inferior cerebellar artery. And then as the vertebral arteries join, they form this basilar artery. So we can see these small penetrating blood vessels that are supplying our bones. Now, these blood vessels are so small, and sometimes they're predisposed to getting ischemic infarcts because they are so small. So sometimes you may have a stroke because of lack of blood supply to this area, and it is what we call lacunar infarcts. So as our basilar artery runs up, we see that it now branches to form the posterior cerebral artery, which is a part of the circle of Willis. So the posterior cerebral artery supplies the posterior aspect of the cerebrum. Moving on to the anterior circulation. So the anterior circulation usually is mainly by the internal carotid artery, and the internal carotid artery is a branch of the common carotid artery, which is a branch of our aorta. So if we follow our internal carotid artery, we can see there are various segments. We have our cervical segment, our petrous segment, our cavernous segment, the cavernous sinus, and then what we call the supraclinoid segment. So this is the cut end of the internal carotid artery, just coming into the brain. So it has 2 main branches. We have our anterior cerebral artery, which moves forward and goes into the longitudinal fissure to supply the anterior aspect of the brain. Then we have our larger middle cerebral artery, again a branch of the internal carotid artery, which moves laterally pierces the sylvian fissure and supplies the lateral aspect of the brain. So the brain, in summary, has our anterior and our posterior circulation. So more on this, we'll start with the middle cerebral artery. It has three main branches: a superior branch, an inferior branch, and this deep penetrating branch. So if you look at this deep penetrating branch, they are very small, supply what we call the globus pallidus, which is responsible for movement in the body. We also have what we call the internal capsule, which runs near the globus pallidus. So the internal capsule is also supplied by these deep penetrating branches of the middle cerebral artery. Again, you can see that they are very small. So sometimes you may find that a patient has a stroke in the middle cerebral artery, and this patient presents with weakness, and you may not be able to pick up this stroke if you do a CT angiogram, because sometimes the vessels are so small, so they may not reflect, and you're wondering why your patient has features of a stroke, but you cannot see anything on the CT angiogram. So we also have our superior division, which supplies our frontal lobe and our parietal lobe, and we have our inferior division of the middle cerebral artery, which supplies this portion, which is our temporal lobe. So moving on to the anterior cerebral artery, we said it's a branch of the internal carotid artery. It pierces forward on the medial aspect of the brain, and it runs upwards and supplies our frontal lobe and our parietal lobe, as well as our corpus callosum, which supplies both sides of the brain. We can see that it runs forward and then back posteriorly. And if you remember our homunculus is around here, and this particular portion represents the legs. We'll go over the homunculus. So if you find a patient coming with a stroke who has weakness more on the lower limbs than the upper limbs, then you think that this patient may have a stroke in a branch of the anterior cerebral artery. If you look at our homunculus again, this portion usually represents the trunk, the face, and our upper limbs. So if you have a patient presenting with a stroke in the upper limbs and weakness is more in the upper limbs than the lower limbs, then we think that we may have a stroke in the superior division of our middle cerebral artery. Again, running through our posterior cerebral artery, it supplies our cerebellum. We said we have our posterior, inferior, anterior, inferior, and superior cerebellar arteries. So if you have a patient coming with an ataxic gait, nystagmus, what we call dysmetria, and dysdiadochokinesia, then we think that we could possibly have a stroke in the posterior cerebral artery. Again, if you have a patient coming with visual disturbances, we may consider that this patient possibly could be having a stroke in our posterior cerebral artery, which supplies our occipital lobe, which is the main visual cortex. So this is just a diagram to show the functional areas of cerebral cortex and its blood supply. So the yellow portion is the middle cerebral artery. We've gone over how it supplies the brain. So this is the lateral aspect of the brain. So it supplies the frontal lobe, parietal lobe, and a portion of our temporal lobe. And when you look on the medial aspect, it supplies just below the corpus callosum and a small portion of the medial aspect of the temporal lobe. If you look at the brain from inferiorly or down, you can see the blood supply of the middle cerebral artery. Anterior cerebral artery, as the name mentions, supplies mainly the anterior portion of the brain, while the posterior supplies the posterior portion of the brain. Now, what I want you to note is that this particular portion where we have the termination of the anterior cerebral artery and middle cerebral artery. This particular portion have end arteries where the arteries terminate, and they're predisposed to what we call watershed strokes. So watershed strokes is like when you're a farmer and you have a field, and the last portion of the field is probably the one that will receive the least blood supply. So if you have, for example, a pediatric patient who comes with hypotension due to acute gastroenteritis, they may end up having what we call a watershed stroke, which is a stroke in these particular portions where the different blood supplies of the brain meet. And it's also important to see the blood supply for the deep structures of the brain. So this is just a reminder of our brain and what the functions of the brain are. We have here our frontal lobe. Our frontal lobe is responsible for mainly higher executive functions. And what we mean by higher executive function, we mean attention, attention to detail, activity, being able to perform your activities, concentration, problem solving, thinking, memory, personality. So usually if you have a pediatric patient with a stroke in the frontal lobe, they may present with features of attention deficit hyperactivity. They'll have change in personality. They will not be able to perform well in school. Then we also see our frontal lobe. So right here we have our, what we call the the motor cortex, or the precentral gyrus, which lies ahead of the central sulcus. So this precentral gyrus is the main motor area. It's a part of the frontal lobe. So if you have a stroke affecting the blood supply here, the patient will present with weakness. So this is our frontal lobe. An important area is this Broca's area. Broca's area is responsible for control of speech. So again, if you have a stroke in this area, the patient may present with what we call non-fluent aphasia or Broca's aphasia. Then we have our parietal lobe here. We have our somatosensory cortex. So usually a stroke involving this area, the patient will have loss of sensation of pain, temperature, proprioception. The parietal lobe is also responsible for body awareness or spatial sensation, knowing where you are in space and time. For example, if you're seated in a chair, you know that you're seated in a chair. So if you have a stroke in the parietal area, you'll have loss of sensation and loss of spatial orientation. Then we have our occipital lobe here, which is mainly responsible for vision. We have our temporal lobe area. So an important area in the temporal lobe is what we call the Wernicke's area. It's responsible for language comprehension. So if you have a stroke involving the temporal lobe, you may have Wernicke's aphasia, or what we call fluent aphasia. The patient will present something like this: popcorns, snake, fish, 8 5s. So the patient will basically be talking nonsense. Then we have what we call our cerebellum. Cerebellum, we know, is responsible for posture, balance, coordination of movement. So again, stroke in this particular area will present with problems in this area. The brainstem is responsible for consciousness, consists of our pons and our medulla. It's responsible for breathing and heart rate. So if you have a stroke involving your brainstem, the patient will lose consciousness. And that's why usually when we have the test for confirming brainstem death, which will tell us if the patient is in a vegetative state, or if the patient is minimally conscious, or if the patient is dead. So if you have a stroke in the brainstem, you may have excessive sleepiness, vegetative state. For example, Michael Schumacher, the famous rally driver, had a stroke involving his brainstem. You may have problems with breathing and of your heart rate. So this is a representation of the homunculus. We said we have our central sulcus here. We have the precentral gyrus, which is the primary motor area, and the postcentral gyrus, which is our primary somatosensory area. So this is a representation of the motor aspect in the brain. So we know that our feet and leg is usually represented medially, and as we move laterally, we have our trunk, shoulders, hands, and the face, the tongue, and the jaw. So if you have a stroke in this particular area, you may have problems with facial expression. In this particular area, problems with weakness. And this, again, is the representation for sensation. So this is just a brief overview of how so if you have a patient presenting in front of you, how do you localize where the lesion is? I won't go over everything because it's what I've talked about, but this presentation will be available to you. We can take an example. If the patient presents with weakness of the right face and arms of the upper motor neuron type, meaning it's spastic, if the patient has a non-fluent or Broca's aphasia, which I've mentioned, then we think that this patient possibly has a stroke in the left middle cerebral artery. Remember, the left side of the brain controls the right side of the body and vice versa. If you have a patient, for example, who comes with a right pure motor hemiparesis, which is weakness of the entire right side of the body, then we'll think that this patient possibly has a stroke in the deep branches of the left middle cerebral artery. Remember, we mentioned that our internal capsule usually passes here, and the internal capsule contains our corticospinal and corticobulbar tracts, which control motor activity of the face and the limbs. So this patient will have complete weakness on one side of the body. So you'll go over these examples. This is what I had mentioned, watershed area stroke, also known as borders infarct, which occurs in the borders between the cerebral vascular territory, where the tissue is farthest from the arterial blood supply and thus most vulnerable to reduction in perfusion. This stroke may often be preceded by precipitating circumstances that include hypotension or hypovolemia, patients with acute GE in hypovolemic shock, severe hemorrhage from following a road traffic accident, and they have features of a stroke. Then and when you do your imaging, you see these hyperintense lesions on your MRI, then you suspect that this patient possibly has a watershed stroke. So as I said, I will be focusing more on arterial ischemic stroke today because the scope will be too large. So ischemic strokes account for up to 1 in 3,500 newborns and 1 to 2 in 100,000 children annually in Western countries. Strokes are higher in newborns than older children, and the highest is in infants and children who are less than 5 years of age, and specifically in boys. In Black and Asian children, strokes are more likely to occur. Why is this? Because sickle cell disease usually occurs more in our African population. So how do we classify strokes? It's based on etiology. There are multiple etiologies, but these particular etiologies that I'm discussing are specific to the pediatric patients. We can have what we call cerebral vascular disorders. Arteriopathies are basically problems in the arterial vasculature, atrial dissection, vasculitis, which is inflammation of the blood vessels, and Moyamoya disease. I hope I'm still audible.
Yes, you are. Go ahead.
All right. Then we have congenital heart diseases, tetralogy of Fallot, patent foramen ovale. We have cardiac diseases acquired such as myocarditis, arrhythmias, surgeries and procedures. Infections such as CNS, meningitis, varicella, COVID-19 are common causes of stroke. Traumatic brain and neck injuries, for example, the case we had of the girl who fell with a toothbrush in her mouth, autoimmune disorders such as lupus, acute systemic conditions such as malignancies, leukemias, vasculitis, chronic systemic conditions such as homocystinuria, sickle cell disease, which is very common in our setting, and hemolytic anemias, hypocoagulable states such as protein C, protein S deficiency, sickle cell and malignancies, genetic disorders such as connective tissue disorders, Ehlers-Danlos syndrome, acidemias, lipoproteinemias, and sometimes the cause is unknown. So I'll just discuss a little bit about specific ones that are common in our setting. We'll begin with arteriopathies. They're actually one of the most common causes of stroke in pediatric patients. So cerebral arteriopathies are basically disorders that affect the arteries of the brain. They include what we call focal cerebral arteriopathy of childhood, which I will discuss, Moyamoya disease. We actually had a case of Moyamoya disease in the ward about 6 months ago, arterial dissection, as well as vasculitis. A quarter of the cerebral arteriopathies have no known cause, and cerebral arteriopathies are reported in about 30 to 50% of all children with arterial ischemic stroke. So focal cerebral arteriopathy of childhood, I know the name sounds a bit complex, but let's try and understand what it is. So it's usually idiopathic stenosis of the intracranial arteries. So there's a study, the International Pediatric Stroke Study found that focal cerebral arteritis actually accounted for 25% of the cases of arteriopathy. The only independent predictor of this is usually recent URTI. So patients who have had an upper respiratory tract infection sometimes develop this focal cerebral arteritis. Unilateral stenosis of the internal carotid artery, which we said supplies the anterior aspect of the brain, and proximal circle of Willis vessels, which include our middle cerebral, anterior communicating artery, are the most common features that we see in focal cerebral arteritis. Now, this particular arteriopathy, it may worsen over the first 3 months after the stroke, but usually improves after 6 months of presentation. Stroke usually occurs specifically in the lenticulostriate vessels, which are those deep blood vessels that I had discussed of the middle cerebral artery, which supplies the basal ganglia and the internal capsule. So this imaging is an example of a 5-year-old boy who was diagnosed to have focal cerebral arteritis. So these are MRI images. This is what we call a diffusion weighted MRI. This is what we call an ADC MRI. They're very specific for identifying acute ischemic stroke. So we can see that there's a hyper-intense lesion here. If you remember the diagram I had projected, this is where our basal ganglia lies and our internal capsule. So this patient may present with a pure motor hemiparesis, meaning that they will have weakness on the right side of the body because we see a lesion on the left side of the body. And when this particular patient did a magnetic resonance angiography, we can see that this particular area, there was an obstruction of the middle cerebral artery. And cerebral arteriopathy commonly follows an infection with varicella zoster virus. So vasculitis is basically inflammation of the cerebral blood vessels. It can be primary causes such as following Kawasaki disease. It can be secondary to CNS infections, malignancies, or drugs. It can involve large vessels, for example, the internal carotid artery, a medium vessel such as the anterior cerebral artery, or those small penetrating arteries that I've discussed. They're difficult to diagnose when you have small vessel involvement, as I said, because normal neuroimaging will often turn out negative. That is the angiography. So if you have a patient who has a protracted clinical presentation, known risk factors such as lupus, multiple deficits and lesions, or systemic symptoms like fever, weight loss, and abrupt onset, then you should suspect that this patient could possibly have a vasculitis. Moyamoya disease. Moyamoya is a Japanese word that means puff or smoke. It's a progressive occlusive disease of the distal internal carotid artery. So usually when you have an occlusion of the internal carotid artery, the brain will attempt to form multiple collaterals, which forms this appearance of a puff of smoke. The posterior circulation, which usually comes from the vertebrovascular artery, is rarely affected, but sometimes it can be affected. So typically patients who have Moyamoya disease will present with recurrent transient ischemic attacks or ischemic stroke or intracranial hemorrhage in young adults. Now, there's a very interesting several very interesting publications about how ischemic strokes have been triggered in patients who have hyperventilation. There's actually a case mentioned of a girl who was eating a very hot, spicy food, and she started, when you eat something hot and you're hyperventilating, and it's actually triggered her to have features of an ischemic stroke. So when you have Moyamoya disease, you hyperventilate, it causes your CO2 levels to go down, hypocarbia. We know hypocarbia usually causes vasoconstriction, and that is how you end up having a patient having features of stroke, because the cerebral blood vessels constrict even more in a patient who already has a pathological stenosis. So we have what we call Moyamoya disease, and we have Moyamoya syndrome, which is usually secondary to other factors such as sickle cell, Down syndrome, or what we call neurofibromatosis. So arterial dissection may be spontaneous or following trauma. Again, remember the case that we discussed of the girl with the toothbrush who had a toothbrush in her mouth when she fell forward, and actually she had piercing of the internal carotid artery lumina. So for the arterial dissection, usually what happens is we have an false lumen being formed in the blood vessel. When the false lumen is formed, we have clotting occurring here. The clotting forms a thrombi, which further narrows the lumen and causing features of ischemic stroke in this patient. And with the false lumen, sometimes you can have increased velocity of blood supply, and this patient can actually end up having an emboli. So cervical artery dissection is actually a common cause of stroke in young adults, especially the ones who do a lot of sports. So we cannot talk about stroke without talking about sickle cell disease. It's very common in our setting. In the KNH Pediatric Neurology Clinic, we've seen many, many cases of patients who have sickle cell disease having a stroke. Children with sickle cell disease are 100 times fold increase in the risk of stroke. most of them will have an ischemic stroke rather than a hemorrhagic stroke, which I will not discuss today. So most of the time, they may have clinically silent strokes where they don't really have an acute deficit. And usually it involves the deep white matter from occlusion of these small arteries, as I had mentioned. So this patient may actually have a stroke, but clinically seems fine. Although these silent infarcts are not evident when they occur, you'll actually notice with time that this sickle cell disease patient who keeps coming to you is having a progressive neurocognitive decline. The mother will say this child is not performing well in school. You notice that they're slow. They may have behavioral problems. Why is this? Because they keep having small infarcts which are not noticed until it is too late. Symptomatic strokes often have large vessel arteriopathies, such as involvement of our internal carotid artery, and commonly the presentation will be dramatic with a sudden onset of weakness. May evolve to Moyamoya disease due to progressive narrowing of the internal carotid artery and involvement of our collateral blood supply. The causal pathway of stroke in sickle cell patients is multiple. It can be due to chronic intravenous hemolysis, pro-inflammatory cytokines, activation of the endothelial surface, which we know causes thrombolysis with dysfunction of the blood vessels. So how do we prevent strokes in our setting? So we need to do frequent transcranial Doppler examination. So a transcranial Doppler examination usually involves looking at the brain, and you're trying to look at the blood vessels within the brain, specifically the middle cerebral artery or the internal carotid artery. This is where you usually place the probe, and what you do is you determine the velocity of the blood that is flowing. So if you have an abnormal velocity of more than 200 centimeters per second, then this patient is at risk of having a stroke. If it's borderline between 170 and 199, so if you have an abnormal of more than 200, you need to keep repeating this transcranial Doppler every month. If it's moderate, every 3 to 6 months, and if your transcranial Doppler velocity is within normal, it will be less than 170 centimeters per second, so you repeat annually. So for our patients who have sickle cell disease, we should regularly be doing transcranial Doppler ultrasounds so that we can detect if they are at risk of having a stroke. So there was a landmark STOP trial which found that chronic blood transfusion therapy in patients with an abnormal transcranial Doppler velocity, which is more than 200 centimeters per second, reduced primary stroke risk by 92%. So you do your transcranial Doppler, it's abnormal, then you subject this patient to chronic transfusions because we know that they are at risk of stroke. However, chronic transfusions have benefits, but they have long-term risks such as risk of infection, iron overload, and end organ damage. The role of hydroxyurea in stroke prevention among sicklers is not clear from the multiple studies that have been done, but we know hydroxyurea usually reduces the incidences of crisis in our stroke patients. Cardiac disease, again in KNH, I've seen several patients who have cardiac diseases having strokes. So abnormal cardiac anatomy may increase risk of an arterial ischemic stroke through a number of mechanisms. We can have paradoxical shunting through a pattern foramen ovale. So we have an emboli that can cross over from the right to the left. From the left, it then goes through the aorta, and we say that the aorta is the main arterial is the main branch that gives off the blood supply to the brain, and then this finds its way into the brain. We can have a prothrombotic state secondary to inflammation, such as rheumatic heart disease. This is an inflammatory process. It causes endothelial damage of blood vessels. When the blood vessels are damaged, it can cause formation of thrombi, which again can dislodge and go to the brain, causing a stroke. Iron deficiency anemia and depressed cardiac function. For example, patients who have been resuscitated due to whatever reason, who present in cardiorespiratory failure or arrest, may have strokes. Remember, we said that it can be a hypovolemic event, which can result in watershed strokes. Cardiopulmonary bypass, circulatory arrest, and other cardiac surgical repairs can predispose to stroke. Pediatric specific ventricular assisted devices and smaller extracorporeal life support systems. Children with congenital heart diseases are susceptible to acquired conditions such as infective endocarditis and arrhythmia, which again predisposes them to arterial ischemic strokes. Infections, so preceding infections are reported in a large proportion of patients who have childhood strokes. In the International Pediatric Stroke Study, infection was associated with a 24% increase in arterial ischemic strokes, and the prevalence was inversely proportional to the age, with those under 5 most at risk for stroke. There's no single location of infection that's more likely to be associated with an arterial ischemic stroke, and cases have varied, had varied illnesses such as after a URTI, which we said can cause an arteriopathy, acute otitis media, or an acute GE. So any sort of infection can predispose a child to a stroke. Mechanisms of the stroke are under investigation, but pathological changes in postmortem tissues of patients with infection and arterial ischemic stroke have shown a role of inflammation. We say that varicella zoster virus is one particular virus that has been identified as a cause of arterial ischemic strokes. So we can't forget to talk about COVID-19 because it's of the recent outbreak. We've actually seen an increase in the number of childhood strokes among pediatric patients with COVID-19. The etiology of the stroke is multifactorial. We know that COVID-19 usually gains access to our body through the lungs. The lungs usually express the ACE2 receptors. The SARS-CoV-19 usually has an affinity for the ACE2 receptors. So when it binds the ACE2 receptors in the brain, they are downregulated, taken in by the lung alveoli, and they find the SARS-CoV-19 finds its way into the bloodstream. So as I've said, the etiology of the mechanism of COVID-19 is multifactorial. We have, so there are two theories of downregulation of ACE2 inhibitors, as I've mentioned, or upregulation from the inflammatory process, abnormalities in clotting, and infarction related. So when you have the SARS-CoV-19 infection, it causes production, it activates your monocytes, causes production of cytokines, and we have our cytokine storm, which predisposes to endothelial damage and nuclear cell activation, with the virus directly infecting the brain endothelial blood vessels. So when the brain endothelial blood vessels are affected, then they will activate the coagulation system, and we have formation of a thrombus. COVID-19 is an inflammatory process, so diffuse inflammation of the endothelium will cause further endothelial damage and predispose to formation of a clot. Vasoconstriction can occur. So we know that the S2 usually works, so it's the angiotensin converting enzyme 2, which usually affects the renin-angiotensin system. So when we have a downregulation of the S2 in receptors as occurs with COVID, then we are unable to get rid of angiotensin 2 in the body. Angiotensin 2, we know, is responsible for increasing the blood pressure in the body. So if you have increased blood pressure in the body, you have vasoconstriction of your blood vessels. Vasoconstriction will cause ischemia, and ischemia will cause a stroke. Activation of the coagulation cascade with production of thrombin and platelet recruitment leads to clotting propensity. It has been proven that patients with COVID-19 often are in a hypercoagulable state. Systemic hypotension secondary to cardiovascular compromise by COVID-19 is another etiology of stroke. Elevated antiphospholipid antibody levels. We know that antiphospholipid antibody again predisposes one to a stroke. Co-infection with SARS-CoV and TB meningitis. We know that TB is prevalent in our setting, and there are interesting case studies that have shown patients who have COVID-19 and TB meningitis are actually more predisposed to stroke. Why is this? Elevated D-dimer levels, elevated levels of fibrinogen, which is responsible for forming the fibrin clot, ferritin, and due to elevated levels of ferritin. So both microorganisms, that is the TB and the COVID, induce inflammation and cause a thrombotic environment. We also have multisystemic inflammatory syndrome as a mechanism for stroke, and post-infectious arteritis with cerebrovascular involvement. So trauma and the arterial ischemic stroke. Frequent causes of injury in children with arterial ischemic stroke include road traffic accidents, gunshot wounds, non-accidental trauma, and sports-related. Pathophysiology, again, is stretching or tearing of the vertebral and carotid arteries from sudden and forceful hyperextension and contralateral rotation of the head, a direct blow to the neck or orbit, or laceration of adjacent structures. And this is why it is important in pediatric patients with stroke. When you're doing your CT angiogram, you don't just do of the head, but you must also do of the neck. So resulting dissection, AV fistulas, pseudoaneurysm, and ultimately interruption of blood flow, or causes artery-to-artery thromboembolic events in the brain. Patients at risk of stroke following trauma require urgent imaging, and they require antiplatelet agents, which we know that is available in our settings, such as aspirin, clopidogrel, and anticoagulation agents such as heparin, and if it's long-term, warfarin. Arterial ischemic strokes following mild trauma may occur in pre-existing conditions such as connective tissue disorders and Ehlers-Danlos syndrome. So remember our girl with a toothbrush in her mouth. So this is the mechanism by which stroke occurs. So this is the tongue. So just posterior along the pharynx, the internal carotid artery is usually located here. So if you have a penetrated, sometimes it's called pencil trauma. So if you have a small child sticking in something here, it may actually penetrate, cause a tearing of the internal carotid artery, and this patient will present with a stroke. Remember, the stroke is likely to have involvement of the anterior and the middle cerebral artery. You see this particular patient, this CT scan shows a hypo-intense lesion in the region of the middle cerebral artery. And when they did the CT angiogram, we saw that there was a problem in the internal carotid artery with a dissection. So hypercoagulable states, again, predispose patients to ischemic strokes. Factor 5, so to understand this, you will just need to go over the coagulation cascade. We have our intrinsic and an intrinsic system. Factor 12 is activated, which activates factor 11, which activates factor 9, which activates factor 10. Factor 10 activates in turn, factor 10 and factor 5 activate prothrombin to form thrombin, and thrombin is what usually forms the fibrin clot. Then for the platelets, we usually have plasminogen. Plasminogen activates plasmin, and plasmin is usually responsible for lysis of a fibrin clot. So understanding this pathway will help you understand how hypercoagulable states cause stroke. For example, factor 5 Leiden. So factor 5 Leiden is basically a mutation in the factor 5 gene. So we have abnormal factor 5 being formed. So when abnormal factor 5 is formed, usually we have protein C and protein S, which naturally cause cleaving of factor 5. So if we have an abnormal factor 5, the proteins, activated protein C and protein S will not be able to get rid of this factor 5. So if it's not able to get rid of this factor 5 Leiden, we have more of factor 5 being formed. More factor 5 will activate prothrombin and form more of the thrombin clot, which predisposes to a stroke. And this is the same way in which protein C and protein S deficiency work. We said protein C and protein S need to cleave naturally, factor 5. Deficiency in this means more factor 5, which is able to activate thrombin to form thrombin. Yes, another example probably I can talk about is plasminogen activator inhibitor. Plasminogen activator inhibitor usually works here. So if you have a problem with plasminogen activator inhibitor, it will cause increased amounts of PAI1, which will act on plasminogen and inactivate plasminogen. If we inactivate plasminogen, we'll have less plasmin being formed. And when less plasmin is formed, it will be unable to cleave the fibrin clot and predispose this patient to a stroke. So if you suspect a hypercoagulable state, then you need to do this test to see if there's a problem in the coagulation cascade. So clinical presentation of arterial ischemic strokes. I hope we are still together, Tahina.
Yes, we are. Getting on well, thank you.
Okay, so ischemic strokes in children are quite, it's a difficult primary diagnosis due to variability in manifestations. The age at the time of stroke has an influence on the possible symptoms. Children less than 1 year are more likely to present with seizures and altered mental status, and children more than 1 year are more likely to have focal neurological signs. So the clinical manifestations can be subtle, they can be quite wide. So you have to have a high index of suspicion. The neurological deficits from strokes may only emerge as the child develops, but can impact their life permanently. So you may not be able to see the cognitive effects of a stroke, but as the child grows, you may see behavioral problems, poor performance in school, and you'll note that the stroke had an influence in this child. 60% of children with stroke have permanent neurological deficits, including limb weakness, learning and memory difficulties, visual impairment, epilepsy, behavior and personality changes, as well as swallowing and feeding difficulties. So this is from the Swiss Pediatric Registry for Strokes, and we see that the most common present.
Dr. Lucia? Dr. Lucia, you seem to have dropped off for a bit. We can't hear you. Okay, let's give Dr. Lucia a moment to get back online.
Speech.
Mm-hmm. So while we're waiting for Dr. Lucia to get back online, please remember that if you have any questions, you can post them in the Q&A section and we will answer them after this presentation and discussion with the panelists. Dr. Lucia, are you back? I think we are still having a bit of a network issue. So yeah, I think we can, there we go. I think we are back.
Am I back?
Yes, we can now see your slides again.
All right, apologies for that. So these are the most common causes of stroke in the clinical presentation. So just a little about the signs and the symptoms. Seizures are more common in the younger patients, about 25 to 30%. Seizures at stroke onset always are followed by other stroke symptoms such as focal weakness, level of consciousness. It can be mild to moderate change in level of consciousness. Remember the case that we talked about, the Sickle, who was actually able to talk following a stroke. And usually a third of patients with ischemic stroke will have a change in level of consciousness. For hemorrhagic stroke, loss of consciousness and coma are more frequent. Headaches may also occur. Remember, headaches are quite non-specific. A third of patients with pediatric stroke, acute ischemic stroke, will have a headache, and it's more in older children who are able to verbalize. So occipital headaches would be common in a cerebral stroke or extracranial dissection. Intracranial dissection, you'd have a half-sided headache, which is described as violent, non-pulsating, and lasting for hours or days. So the Pediatric National Institute of Health Stroke Study scale is what we use to kind of describe the clinical symptoms in pediatric patients. It has a very high sensitivity of 87%. Severity of pediatric stroke can be trended over time to assess recovery, and the initial stroke score may predict future disabilities at 90 days. It should, so this PED NIH-SS scale should be used in all children more than 2 years who have clinical and radiological signs of a stroke. In order to improve the accuracy of the NIH-SS score, the patient's family member should refrain from hinting at correct responses for questions asked. So this is an example of the National Institute of Health stroke scale. It's ideal when you get a patient who has features of stroke and you want to determine whether this patient has no stroke, minor stroke, or severe stroke. So it has various features such as level of consciousness, facial nerve palsy, the power in the limbs, if there's any ataxia. So a score of 21 to 42 would usually define a severe stroke. A score of 1 to 4 is a mild stroke, and 5 to 5 to 20 is a moderate to severe stroke. If you have a score of 0, then this patient does not have a stroke. It's important to mention that there are many things in pediatric patients that can mimic strokes. For example, a seizure. We know that patients sometimes who have prolonged seizures can have what we call towards paralysis, which means after the stroke, they have weakness of the limbs. Usually this is due to exhaustion of the receptors at the postsynaptic junction. So the patient will have a period of paralysis following the stroke, and it may mimic a stroke. Migraine headaches, we have what we call hemiplegic migraines, which are patients who have severe migraines presenting with weakness of one side of the body. So there are multiple things that can cause stroke. So always have the differentials in mind when you have a patient presenting with features of stroke. In the adolescent patient, we know that sometimes they can have syncopal episodes, conversion disorders, anxiety, which can present as stroke-like symptoms. So neuroimaging for arterial ischemic stroke, it's the first investigation. So MRI is the ideal investigation. All sequences should be obtained, including what we call T1, T2, diffusion weighted MRI, and its accompanying ADC, which is actually the best for defining strokes. And you should investigate both the head and the neck, especially when you're doing your angiograms. Variable symptoms, difficulty in diagnosis usually point to the importance of neuroimaging in a child with suspicions of stroke, for diagnostic purposes, and also for the evaluation of etiology and long-term outcome. CT scan is readily available, but may miss out on early, small, or intratentorial ischemia, which is a stroke in areas such as the brainstem and the cerebellum. So CT scan is actually not ideal if you're thinking of an acute ischemic stroke. It's ideal if you're thinking of some sort of hemorrhage because it can quickly pick out a hemorrhage. But if you do a CT scan very early in a patient with an ischemic stroke, it may actually appear normal. So the golden standard is an MRI, specifically the diffusion weighted MRI, which will reveal ischemia within minutes. The other sequences such as T1, T2, and gradient echo will supplement the initial investigation. We also have the sequence called FLAIR, which is good for stroke timing. It can help you, when you compare it to the diffusion weighted imaging, it can help you know when the stroke occurred. Magnetic resonance angiography and CT angiography are useful for detecting arteriopathies, which you said are the most common causes of strokes. The best MRI sequence for detection of dissections are a combination of contrast-enhanced MRA, what we call non-fat and fat-suppressed T1 weighted images for the cervicocranial vessels. So if you have a patient with childhood stroke, in our center, sometimes CT scan is what is available. It's quick, readily available, but it has a very high false negative, almost 50%. It may miss other causes of stroke, such as the cerebral synovenous thrombosis and early acute ischemic stroke, as I've mentioned. Consider radiation. Many parents worry about radiation when you're doing CT scan, especially if you're doing the CT angiogram. MRI may more accurately show hyperacute and acute strokes, as well as cerebral synovenous thrombosis. May also be more accurately diagnose stroke mimics like brain tumors. The patient may require sedation. MRA, MRV may be considered to evaluate vessel disease such as arterial or venous occlusion, and magnetic resonance spectroscopy may be considered to evaluate metabolic disorders. We know that metabolic disorders such as MELAS can present with symptoms that are very similar to a stroke. Angiography may be needed to evaluate vascular lesions like aneurysm, arteriovenous malformations, or vasculopathy. Again, the patient will require to be sedated. So these are just examples of MRI sequences in a patient with a stroke. This particular patient had a stroke involving the middle cerebral artery. So this is a diffusion weighted imaging, which we said is ideal for strokes. We see a hyper-intense lesion involving the frontoparietal lobe, and we also have a hyper-intense lesion around the white matter, the deep white matter. This is a T2 imaging that was repeated on day 3. If we compare it with the day 3 DWI, we see that if we look at the T2, we might actually end up missing out on the features of the stroke. But T2 is very good for follow-up because it can tell us if the symptoms resolved. In this particular patient, we see that 4 years after the stroke, most of the symptoms had resolved. There's just a small deficit that is seen in the right area. This patient had an MRA done, which shows very clearly an obstruction in the middle cerebral artery. If you compare with the right, you can see there's narrowing of the middle cerebral artery, just as it emerges at the sylvian fissure. So as I've said, the DWI is the most sensitive for cytotoxic edema. Remember, when you have ischemia, these patients may have a lot of edema around the area of the stroke, and it can actually cause a midline shift. So DWI is a good sequence. It's positive within half an hour of stroke and can be reversible, and it's useful for stroke volume calculation, especially in centers where they do mechanical thrombectomies. So FLAIR, as I mentioned, is good for stroke timer. It can tell you how soon, when the stroke occurred. For example, in this particular case, we have DWI FLAIR mismatch. In the FLAIR image, we cannot see the stroke, but in the DWI, we clearly see the stroke. So likely this stroke has just occurred. In this other patient, we have what we call no DWI FLAIR mismatch, meaning both the DWI and the FLAIR image show you the stroke, and this means that it is a relatively older stroke compared to this one. So what other investigations do you do for a patient with stroke? It will be guided by diagnosis. For example, if you have a patient who has a familial history of sickle cell disease, then you'll need to think about doing HP electrophoresis. If you have a patient who's known to have a cardiac disease, you need to do your ECG and your echo. Arteriopathies, you need to think about doing your MRA and CTA, both of the head and the neck. If you're thinking about hypercoagulable states, you need to do your full blood count, coagulation screen, factor V Leiden mutation, protein C, protein S levels. If you're thinking of an inflammatory response, such as lupus, you need to do your ANA, your ESR, and your CRP. So other investigations will be guided by your history and your clinical examination, but neuroimaging is the most important investigation that you should do. So we'll now move on to principles of stroke management. This diagram is just to tell you time is brain. The sooner you intervene for a patient with a pediatric stroke, the better the outcome for your patient. So irreversible brain tissue ischemia occurs within minutes to hours of an arterial occlusion. The time to irreversible tissue injury is shorter in what we call the central core of the infarct and longer in surrounding penumbra, which collateral arterial supply can continue to perfuse. I'll explain this a bit more. So neuroprotective strategies to balance metabolic substrate supply with tissue metabolic demand aim to increase brain tissue survival, primarily within the penumbra. What do I mean by this? So when you have a stroke, basically you have compromised blood supply. And this is an example of a patient with a stroke. So the innermost area is the core of the stroke. In this particular area, we have complete compromise of blood supply, so the tissue dies, and even with reperfusion, this area will not recover. And this is what is responsible for the long-term consequences of stroke. Then surrounding this core area, we have what we call the ischemic penumbra. The ischemic penumbra is the area of the brain that has somewhat compromised blood supply. So if the tissue, if we don't intervene early, this penumbra can convert to a core and we have complete tissue death. However, if we intervene early for our patient and restore perfusion, then this tissue will survive and this patient will improve. And that is why it's very important to act quickly for a patient with an arterial ischemic stroke. Then we have this surrounding area of oligemia, which most of the time the tissue will survive, and then surrounding normal brain tissue. So protecting the penumbra is a tenacious balance between supply and demand. You want to reduce the cerebral demand, and this can be increased by things such as fever and seizures, which increase the metabolic demand. You want to ensure that you increase supply by increasing blood flow and increasing oxygen so that you can maintain cerebral oxygen delivery. So there are a number of factors that influence how you manage your patients and influence cerebral blood flow. Number one is metabolism. You want to ensure that your patient doesn't have further fevers, doesn't have seizures, because that will increase the metabolic rate of the brain, And this can increase, and the patient will require increased cerebral blood flow. We already have compromised cerebral blood flow, and this patient is likely to do worse. So you don't want your patient with a stroke having seizures or having co-infections. Blood pressure is also very, very important. We know that we have what we call cerebral autoregulation. This means that the blood flow to the brain remains relatively constant to fluctuations in blood pressure within the body. However, if the blood pressure continuously falls, then eventually we have loss of the cerebral autoregulation mechanism, and cerebral blood flow will reduce, compromising the ischemic penumbra even further and making the patient deteriorate. We also do not really want our patient to have hypertension because it's quite difficult to manage hypertension in patients with stroke. Neurogenic basically involves the affected nervous system. This one we can't do much about it, so I will discuss it much. And then we also have maintenance of arterial PO2 and arterial PCO2. So if you have hypercarbia, which is increased carbon dioxide levels in your body, it causes vasodilation. So we know that vasodilation ideally may increase blood supply in the brain, but it can induce what we call Still syndrome in patients with stroke. And Still syndrome basically means because the blood cannot flow a certain area, it will follow the path of least resistance, which is the areas that are already perfused, causing worsening of stroke syndromes in the penumbra area. Hypocarbia, which is low PCO2 levels, hypocarbia naturally causes vasoconstriction, and we don't want vasoconstriction because it will further compromise blood supply to the brain, worsening the signs of the stroke. And arterial PO2, we want to ensure that our patient with stroke has efficient oxygen levels, ideally more than 94%, which will ensure continued delivery of oxygen in order for the brain to function well. Cardiac output, we know, is very important. Patients, we say, do have hypovolemia that will further compromise blood supply to the brain, and we say it can cause things such as watershed strokes. So stabilization and supportive care is very important. We start with our ABCs. Maintain your airway, make sure it's patent because these patients may have a compromised airway if they're having seizures or loss of consciousness. Breathing, ensure that this patient SpO2s are more than 94%. Circulation, we have talked about adequate cardiac output. So when you have a patient with a stroke, it's essential that you fix your line early in case you need to supplement the circulation. Maintenance of normal blood oxygen and carbon dioxide. Normocarbia is important. The patient, treat any fevers, ensure that you have normal tension, normal volemia, and normal glycemia. Children with sickle cell disease and stroke, ensure that they have adequate hydration, exchange transfusion to maintain the HbS to less than 20 to 30%. Management of seizures and raised intracranial pressure is important. Raised ICP, we can manage with things such as mannitol, hypertonic saline, or sometimes we need to call the neurosurgeon to perform a hemicraniectomy if we have features of midline shift. So rapid emergent decompressive craniotomy in cerebral edema, not responding to medications such as mannitol or impending herniation would necessitate involving the neurosurgeons. So for seizure prevention, as we said, clinical seizures are quite common in ischemic stroke. Subclinical seizures are actually found in patients with prolonged EEG monitoring. Unfortunately, in KNH, we have a problem with the EEGs. We don't have them within the ward, so most of the time we have to outsource for patients who are within. But ideally, if you can do continuous EEG monitoring, that will be good because sometimes we have what you call subclinical seizures, which are seizures that we cannot see. And so that is why it's important to do your EEG for your patient with a stroke. Seizures, we said, increase the cerebral metabolic rate, and they may hasten the fate of the penumbra to cell death. No data on use of prophylactic anticonvulsant therapy is available. However, if your patient is having a stroke, then you initiate on anti-seizure medication based on local protocol. I've talked about carbon dioxide. We don't want hypercarbia, we don't want hypocarbia, so we want to aim for a normal carbon dioxide levels. Cardiac output and BP, there's lack of evidence on a particular blood pressure range. So blood pressure should be not too high, not too low. So probably between the 50th and 99th percentile for
Dr. Lucia, I think you've dropped off again. One moment while Dr. Lucia gets back. Let me just message. Okay, a moment please while we wait for Dr. Lucia. Please post your questions in the Q&A section so that we can answer them while once Dr. Lucia is back. If you have anything that you'd like to discuss or raise, point out to the other participants, you can put it in the chat. I can see some of the participants are saying that it's a nice presentation. And I think that we can see that from the discussion today, we are having more, these are more common. You can see Dr. Lucia is back. Dr. Lucia? Excellent.
Are you able to see the slides?
Yes, we are.
All right, so I was talking about pharmacological and mechanical thrombolysis. So we have what we call pharmacological thrombolysis as well as mechanical thrombolysis. So pharmacological thrombolysis involves the use of tissue plasminogen activator. Remember the diagram that I showed you, plasminogen usually activates plasmin and plasmin dissolves the fibrin clot. So use of tissue plasminogen activator as well as mechanical endovascular thrombectomy have shown benefit in adults with arterial ischemic stroke when implemented earlier. However, the use in childhood remains controversial and they are not recommended outside clinical trials. May be used in consultation with a pediatric neurosurgeon as well as a pediatric neurologist in carefully selected cases. So I'll talk a little bit about tissue plasminogen activator. So tissue plasminogen activator or thrombectomy improves stroke outcome in adults. As I said, it's not recommended in pediatric stroke guidelines, but may be reasonable in some situations under the guidance of a neurologist with experience in pediatric stroke, which unfortunately we do not have locally. Vascular imaging that demonstrates a complete or partial obstruction of the vessel is required, in addition to radiological, clinical, and laboratory support. So I'll just try and simplify this diagram, but this was a study done by Ijaktovic et al. In 2015. So what they showed was that actually in pediatric patients, they have less fibrin in the clot compared to an adult patient. So tissue plasminogen activator, as I've said severally, activates plasmin, and plasmin usually dissolves the clot. So thrombus composition impacts effectiveness of recanalization therapies, but children, we've said, have less fibrin in the thrombus. So does this tissue plasminogen activator really work effectively? This suggests use of thrombolytic therapy could be theoretically important in pediatric patients, but we don't really know. And we also don't know the dose to use. So theoretically, it can be used in consultation with someone with experience. So mechanical thrombectomy is essentially going in for surgery and removing the clot. So it's a potential appeal for childhood ischemic strokes over the tissue plasminogen activator, because we don't really know the dose for the tissue plasminogen activator. And usually for the tissue plasminogen activator, usually you need to use it in adults within 4.5 hours of the stroke. So the total number of children who have been treated by mechanical thrombectomy is not really known. I asked a neurosurgeon in KNH, and they've never done a case of mechanical thrombectomy in pediatric patients. Safety profile of endovascular thrombectomy in children also remains unknown. So moving on to anticoagulant therapy, it includes heparin, unfractionated or low molecular heparin, as well as warfarin. It's recommended for proven arterial dissection, like the case that we had, severe thrombophilia, as well as cardioembolic stroke. So significant hemorrhagic transformation in childhood arterial ischemic stroke is rare. It's contraindicated. Contraindicated in cases of intracranial bleeds, sickle cell and bleeding tendencies, and longer term for cardiac and severe prothrombotic disorders. So if you have a patient with a hypercoagulable state or some sort of cardiac disease, then you may consider using anticoagulant therapy for long. Ideally, we usually start with heparin, but if you need to use it long-term, warfarin can be acceptable. It's very important to look out for heparin-induced thrombocytopenia, so you need to regularly do your TBCs. We have our antiplatelet agents, which include aspirin and clopidogrel. Treatment recommendations are based on extrapolation of adult experience and expert opinion. Safety and efficacy in pediatric patients is not known. Management guidelines recommend antiplatelet agents for secondary prevention in non-cardioembolic stroke, especially for arteriopathies. So aspirin usually works by acetylating of the enzyme COX, which interferes with production of thromboxane 2, thereby irreversibly inhibiting platelet aggregation. And we know platelets are a component of the thrombi. There's a risk of hemorrhagic transformation with use of antiplatelet agents, although very rare. And there's also a risk of Reye syndrome. Varicella vaccination and influenza vaccination are recommended in patients who are on prolonged aspirin use. So rehabilitation for the stroke patients. So given the plasticity of the young brain, meaning that for a child, the younger the child, the more likely the brain is to adopt and find new ways to work. So given this plasticity of the young brain, rehabilitation can lead to improvement in long-term outcomes with a favorable impact on the long-term mobility, quality of life, and emotional health for the child. Multidisciplinary team must be involved in rehabilitation of these patients, including the OT, the physiotherapist, the nutritionist, as well as involving the school where the patient goes. So in summary, strokes may have subtle presentation in children and a wide differential diagnosis, which may delay diagnosis and even cause missed diagnosis with these patients. So we have complex etiological investigations that may need to be done. MRI techniques are considered the gold standard of neuroimaging, especially the DWI, and early supportive care is essential to protect the penumbra. There's lack of evidence-based treatment, so a lot of the treatment is based on extrapolation from adult population, which help clinicians in deciding how to manage pediatric stroke. These are my references. Thank you. I'm now open for questions.
All right. Thank you so much, Dr. Amolo. That was a very, very detailed and yet not overwhelming presentation. I'm sure, as you can see in the chat, we have so many people saying it's insightful, it was very good, and I'd like to echo those thoughts. So I can see that Dr. Kigathi is on as well. So I think perhaps you can take the questions together with Dr. Kigathi, if that's all right with you. So the first question that I'd like to field to you is from George, who asks in the regarding MRI or DWI, can it be done in early childhood? I'm not sure what he means by early childhood, but how young can a child who gets this MRIs done?
It can be done in the neonatal period. There is no concern, there are no safety concerns. So it can, as soon as you suspect a stroke, whatever the age of the patient, you must do the entire MRI sequence, including the DWI, the ADC, the FLAIR, the T1, the T2, and if possible, you also do MRA. So there are less risks like with CT angiogram. One of the concerns is usually exposure to radiation, but MRI DWI can be done at any age, including the neonatal period. And we commonly do actually neonatal MRIs for patients who have birth asphyxia. And this usually can be predictive actually of long-term outcome.
Okay. And perhaps we could just mention here that maybe we don't see as many MRIs being done. It's because of the other things that we require when we're doing MRIs, such as maybe sedating the patient or monitoring the patient, because it's quite a long procedure. So I think that might be the only thing that is might limit that. But yes, as Dr. Lucia says, we do it through all ages. It's very useful, as we've seen, even checking the timing, correct?
Yes, maybe the only concern in KNH is sometimes we have delays because of the large number of patients booked in MRI. So maybe what we can do is just develop protocols where we inform the radiologist in case we are suspecting a stroke so that this patient can jump the queue. Because as we said, the earlier, the better.
The better. Okay, excellent. So there's another question that we have here, which says, can the NIHSS score tell you if it's hemorrhagic or ischemic, a stroke? And will it help you start blood thinners or not?
So the NIHSS score will tell you if there's a stroke. It will not tell you if it's hemorrhagic or it's ischemic. To differentiate between a hemorrhagic and ischemic stroke, you must do neuroimaging. If you're highly suspicious that it's a hemorrhagic stroke, you can actually do a CT scan, which can be done much faster, because the CT scan, you will just see this bright, hyper-intense lesion, which will tell you that it is a bleed. However, the NIHSS is just used for scoring and not for differentiating between the two.
So more
and will it help if you start blood thinners or not? You must exclude a hemorrhagic stroke before you start the patient on any blood thinners. So that is why neuroimaging is essential in your pediatric patient, because if you start blood thinners and it's a hemorrhagic stroke, things will get worse.
Yeah. All right. We have another question. Do we routinely use the antiplatelet? I think he means the junior aspirin. He wrote JASA in a sickle cell stroke.
No, we do not routinely use it. As I said, there are specific conditions which you would consider to use it. If a patient has a long-term risk of a stroke, such as hypercoagulable states or certain cardiac diseases where they're predisposed to cardioembolic strokes, then you can give the junior aspirin. For the sickle cell disease, as I mentioned, what we should ideally do is regular transcranial Doppler ultrasound. If you do a transcranial Doppler ultrasound and you find that it's abnormal, meaning a velocity of more than 200 centimeters per second, then you must do more frequent transcranial Dopplers and subject this patient to continuous blood transfusions.
Okay. Let me just check. So we do have a question on hemorrhagic strokes, but I think perhaps that could be a topic for a future session, because today we were focusing on ischemia. Somebody has a question regarding the child with the toothbrush accident with no neurological deficits. What was her management following the incident?
So the child with the toothbrush incident, then we say that the patient had a dissection of the internal carotid artery. So we should start this patient on antithrombotic medication so that we can prevent worsening of the symptoms. But this can only be done once you've done your CTA or MRA and confirm that this patient actually has an arterial dissection. Then you want to start your antithrombotic medication. So you can start on heparin, low molecular weight heparin at a dose of 1 milligram per kg. And you do it with continuous monitoring. You need to keep doing your coagulation profile. Most of the time, you won't need to do this treatment very long term. From what I read, usually it's done for about 2 to 4 weeks. Sometimes it may be a bit longer, but you keep monitoring by doing the neuroimaging so that you can see if there is repair. If it's a very severe tear for your patient, then sometimes you need to involve the neurosurgeon so that this patient can go in and you have repair of the arterial dissection. Because we say that when you have the arterial dissection, you can have a thrombus forming between the two layers of the artery.
Okay. So we do have a question regarding now again the role of thrombolysis and statins in pediatric ischemic strokes. What would you like to say anything about that?
Bill, do you have anything to say about that? The statins.
Okay, no, the use of statins is not it's not routine in pediatric ischemic strokes. So as you've seen, most of pediatric ischemic strokes are from other inflammatory conditions that are happening in the child's circulation. So statins wouldn't be used routinely. Thrombolysis, again, as Lucia was saying, would be, it's important for you to make sure that you have the ischemic strokes, and then you confirm that it's an ischemic stroke, and then thereafter you try and identify what the particular cause is, because pediatric strokes are from a wider range of causes. So the response to thrombolysis differs according to the cause. So you'd want to try as much as possible to give as strong supportive treatment as possible. And then if you find those situations where you're having thrombophilia, that's where your thrombolysis would help.
Mm-hmm. Thank you for your input, Dr. Kigasi. There's an interesting comment here that says that we were taught that children should not play while sucking lollipops, and they think that this is still a worthwhile precaution. I think we agree at the moment. So there's another question here. Any role of products like pentoxifylline in SCA-related stroke?
Sorry, could you repeat that?
I don't know if I'm saying it correctly. Any role of products like pentoxifylline in sickle cell related stroke? I don't know if the person who asked, Mithwani, would like to clarify in the chat what he or she meant.
I think, no, there's no role of pentoxifylline in sickle cell strokes. I think it's a blood thinner, usually used for patients who have peripheral arterial disease. And no, we do not use it in patients with stroke.
Okay. So I think that we've answered most of the questions. Would you like to make any summary, or does Dr. Kigathi, I see your hand is up. Would you like to add on to the discussion that we've had? Hello?
You can unmute, Bill.
Yeah.
So I'd like to thank Lucia for a very comprehensive presentation. She's covered a lot in a short period of time in a very comprehensive way. Just a note for us who are seeing patients in Kenyatta. We've been noting that even in the neurology clinic, there are many children who are coming with very subtle neurological deficits. They come in with a facial nerve palsy, they come in with a first-time seizure, they might come in with a slight weakness over a period of time. Many of these children are being reviewed and discharged home, which I think is a big disservice to them, because we are actually missing a lot of these subtle strokes. Sometimes it's a child who comes on the second, more severe stroke that a child is now admitted and processed. Then when you do the radiology or the scans, you find that there were previous older strokes that had been happening in children, especially those with either coagulopathies or those who had certain vascular anomalies, some who had sickle cell. Sometimes they are not caught on first contact. So I'd urge that even if you may have a child who comes in with any subtle neurological deficit, it might be slurring of speech, it might be a sudden squint, it might be a sudden facial nerve palsy. Even if you're in doubt, also these children would benefit from one, either consulting a senior at the time they are in the clinic. Perhaps you may want to observe them for a day or two in the wards. Then at least that way, then they can benefit from further investigation and the investigations you'll be able to do on an outpatient basis. Because sometimes we are missing many of these children who are coming in with those subtle strokes. The strokes that if we treated early, you would end up with a child without any disability or any neurodevelopmental issues. But allowing it to progress to the point where it's a very huge event, that can easily lead us to having children who are disabled or who have neurodevelopmental issues. That's my main point for our follow-up. And then we'd also want to indulge radiology. Sometimes when we have these children, we might be pushing for a child to have an MRI done sooner than the booking, as it were. But I think Dr. Lucia has touched on the fact that we are trying to conserve as much brain as possible. So sometimes we might be indulging radiology for those early MRIs to help us diagnose the extent and severity of the stroke. Thanks.
Hello? Hello?
Yes, those are my comments.
Okay, so thank you. We need to, I agree, Dr. Kigathi, we do need to be more keen at those reviewing children. Dr. Amolo, do you have anything to add or to summarize, like a parting shot?
Well, I'll just summarize by saying, as I said in the other slide, time is brain. So if you're ever suspicious that a patient has a stroke, act quickly.
Mm-hmm.
Thank you.
Yes. So thank you all for attending this afternoon's session. You can currently see the CPD tokens for the nurses being projected at the moment. We invite you to tomorrow's session, which is World TB Day. We'll be having Professor Elizabeth Obimbo presenting to us. I'd also like to take this opportunity once again to thank Dr. Amolo. That was an excellent presentation, and Dr. Kigathi for contributing to our discussion. So thank you very much, and we look forward to seeing you tomorrow on World TB Day so that we continue the battle against tuberculosis in children. Thank you very much.